welcome to mechanical ventilation. We are going to look at initiation of mechanical ventilation and some of the things that we need to remember when we're doing that. We know that the 4 life functions that must always be in balance or homeostasis, we learned early on in respiratory school, are ventilation, oxygenation, circulation, and perfusion. The most important one of those that we're always going to prioritize is ventilation. So we're going to listen to breath sounds, tidal volume. We're going to watch the PCO2 on the blood gas. For oxygenation, we're going to watch the PO2 and the heart rate, as you know. For circulation, we're going to watch things on the monitor like cardiac output, pulse, and blood pressure. And we're going to watch perfusion by monitoring the hemodynamics continuously. So we get the patient into the emergency room or we report to the ICU, CCU, and one of these life functions has failed. And so we need to look at which one it is, or it may be more than one. And if it's ventilation and oxygenation, especially ventilation, we need to look at getting them intubated and on the ventilator as soon as possible. And then once we get them onto the ventilator, we're going to start the working toward weaning as soon as possible. We don't want anyone to stay on the ventilator long term that doesn't absolutely have to, okay? So the first thing we're going to look at is what we need for intubation. You want to have, first of all, you want to have your crash cart by the bedside. You want to have your ambu bag or your resuscitator bag. The politically correct term for it is resuscitator bag. You want to have the oxygen flushed at 100%. You want to have your Mack and Miller blades out and allow whoever is intubating, whether it be you or the physician or anesthesia, allow them to choose which one they're most comfortable with for this particular patient. Remembering that the Miller blade is the straight blade and the Macintosh blade is the curved blade. We also want to have our correct size tube out. So for intubating an adult female, you're going to want to have a 7 and probably a 7.5. If you're intubating a male, you're going to want to have an 8 and maybe an 8.5 out. Of course, it's according to their height, weight, and size to which one that you're going to choose. And so we want to have our suction going. We want to have it flushed, make sure that it is working. You want to have your 10 cc syringe. You want to have your end-tidal CO2 monitor or the color change monitor to make sure that you're in the trachea and not in the esophagus. You want to have your tube tamer or your tape out and ready to use to secure the ET tube. You want to have your stethoscope out so you can listen to breath sounds, and you want to have x-ray on standby to make sure they're ready to do the x-ray, chest x-ray, so we can make sure the tube's in the correct place. Our goal, of course, is for the tip of that tube to land 2 to 4 centimeters above the corona. The easiest place for it to slip if it goes too far, as you remember, is in the right main stem. We want to have it back where it needs to be, though. That way both airways to the left lung and to the right lung are ventilated, so we get a nice even flow and volumes bilaterally. And so we get this all together, and we have our ABG kits nearby. We have everything that we need. And we have a portable ventilator so that we don't have to stand there and bag for endlessly. And we've got everyone in place. You get the patient intubated, and now we're going to put them on the ventilator. So the first thing that you want to do is determine the tidal volume. And for an adult who doesn't have ARDS or isn't into a severe asthma attack, we're going to go with 6 to 8 milliliters per kilogram. And we of ideal body weight. Remember, we don't base it on actual body weight, but ideal body weight instead. So remember your formula for that. Then we're going to set our respiratory rate at 10 to 12 breaths per minute. If we're going to use pressure control, we're going to use less than 35 centimeters of water. If we're when we set the FiO2, we're going to go with 40 to 60%. And then the PEEP is going to start at 5 and work your way up from there if you need to. Don't worry about the mode. You can use assist control SIMV, or you can use PRVC if you've got a ventilator like the Servo I. You can use PRVC to put the patient in, kind of the best of the both worlds. So if they don't need pressure control, you can use a volume mode and stabilize your patient as soon as possible. Now, if you do have an asthmatic patient, you're going to want to do more of a 4 milliliters per kilogram to start with. And if you have an ARDS patient, you're going to want to do 4 to 6 milliliters per kilogram to start with. Don't be afraid to use your PEEP as you get the patient on the ventilator. If you're monitoring them and they're not responding to being on the vent and having the FiO2 and the PEEP working together, if they're still hypoxic, you can go ahead and start adjusting your PEEP up. You want to go in increments of 5 or so and give them time to react to it, and that's just going to hold that airway open and help oxygenate the patient, hopefully. So follow your ARTS-NET protocol in order to continue to adjust the ventilator until you have that patient stabilized. So just watch your blood gas and watch your cardiac output, watch your hemodynamics. Positive pressure does have an effect, as you know. It decreases venous return to the heart. It decreases cardiac output. It puts a squeeze on the heart so it's not able to pump out as much as it normally would be in a natural state. And so that extra positive pressure in the airway just kind of puts a little bit of discomfort on the heart, and it may just make it hard for it to put out a decent cardiac output, and you don't want to have that in play. So watch your hemodynamics. So make sure that make sure your tidal volume is adequate. It's not too high, it's not too low. Multiply out your ideal body weight, like we talked about, times 6 and times 8. That'll give you your low range and your high, and then you want to not go out of that range when you're making your decisions on your tests and in the real world, okay? So make sure that you're remembering it is based on ideal body weight, not on actual body weight. As we gain weight, our lungs do not grow. Think of it this way: if they did grow and you had went on a diet, you would have to have your lungs reduced in size. I know that sounds silly, but it's just a good way to remember. Lungs don't grow when you gain weight, okay? So once we get the patient on the ventilator, we're going to do some calculations. We're going to monitor the blood gas. We're going to monitor heart rate, make sure it stays in range. We're going to monitor respiratory rate. We're going to set our alarms. We're going to watch for the alarms to activate. If you have a low pressure alarm, you know you've got a leak. You may have a leak in the circuit. You may have a leak in the cuff of the ET tube. You may have a leak pretty much in the exhalation valve may malfunction. But if you have a high pressure alarm, you know that the vent's having to work harder to deliver that breath. And so it's having to give a higher pressure in order to get the tidal volume that you've chosen for that patient into the airway. So we want to keep a good eye on those. If you get a high pressure alarm, your tubing may be kinked, your patient may need suction, you may have water in the corrugated tubing that makes up the vent circuit. So something is coming between the ventilator and the delivery of the breath to cause extra work. So you just need to find what the issue is and correct it, and that should correct your high pressure alarm. So if it's not a an equipment issue, you could be having some other things as far as anatomically causing the high pressure alarm to sound, like increased airway resistance. If you've got some bronchospasm going on, so you'll have to give some type of bronchodilator like albuterol or Duoneb to open up the airway. You may have to give Solumedrol if it's not corrected by an albuterol and atrovent or a Duoneb treatment. You may have to go with a corticosteroid to get that airway open. So you also may have a decrease in compliance that's causing your high pressure. So you need to find out if you have an ARDS situation beginning and try to get that corrected as soon as possible. So it's really hard to keep everything balanced out if you've got an unstable patient, but the more experience you get with it and the more experience you get with troubleshooting, then the easier that's going to be. So you want to remember your calculations to find your compliance and your airway resistance. You want to remember that PIP minus plateau gives you your airway resistance, and you need to listen to breath sounds to find the wheezing. You need to look at your tubing to see if maybe the ET tube is kinked. Sometimes that happens. The patient starts coming out of sedation, and sometimes they bite the tube. There may be secretions in the airway that you need to clear. So whatever it takes to clear that circuit, if it is an issue like that, to get the high pressure alarm corrected is what you need to learn to look for. Okay, some other troubleshooting that you may need to do. Do you have some atelectasis that's causing your peak pressures to go high? You would have to get a chest x-ray, listen to breath sounds. Do you have pulmonary edema coming into play? Do you need to give a diuretic and maybe something to help the heart pump with more vigor, like digoxin or digitalis, in order to kind of help clear any extra fluid? So learning to look for what's causing the issue and how to correct it is something that we have to absolutely perfect in this field. So make sure that you set your alarms correctly. Don't increase the alarm limit just because it's going off. Instead of doing that, find the problem and correct it, and don't increase your alarm limits in order to just silence the alarm. That's never the answer, okay? So you're going to be taking a lot of trips with your event patient potentially. You may have to go to CT scan, MRI. They may transfer them to a different ICU. So remember that when you take a trip with a vent patient, you want to make sure that portable vent has a secondary apnea alarm on it. So if the patient stops breathing, it's going to alarm you. And it has a low pressure alarm as well. So if they become disconnected, it's going to alarm you. You can get busy, talking with the person transporting, making turns in the hallway, running, to get the elevator to open doors, things like that. And you need to make sure you're paying attention to your alarms. Make sure they're functioning. Never leave the ICU or the ER without an ambu bag. Oh, I did it again. Without a resuscitator bag with you, and adequate oxygen to make the full trip, and have a little extra left over, because sometimes you get held up on trips like that. So make sure you've got more than enough oxygen. You've got a resuscitator bag with a PEEP valve on it. If you're using PEEP on the portable vent or on the stationary ventilator and you need to bag the patient, make sure that you've got a PEEP valve on your resuscitator bag set at the same amount of PEEP. That way you're able to continue to give that therapy regardless of what you're using to ventilate the patient with. That's super important. So also, once you return to the room, and you're going to want to take whatever test results that you get back, come up with a care plan with the physician and the care team, and try to begin working towards weaning. That's our primary goal once we put somebody on the vent, is to get them back off as soon as possible. So make sure that you are keeping a close eye, not just going in and checking the vent, but looking for changes and reporting those changes to the doctor, making the changes that you are allowed to make based on your protocols. And then once you get ready to actually begin the weaning process, just follow the steps that are in your weaning protocol. Remember to calculate RSBI, and your RSBI should be less than 106 before you begin to wean. Your patient needs to be stable, so if you are on the test or in real life, you are doing a weaning procedure and your patient's heart rate goes up, blood pressure goes up, they become diaphoretic, then you know you've got to stop that weaning and try again tomorrow, So take your time. You don't want to extubate and then end up having to re-intubate. Remember, if you see a question on the test and it is about extubating a patient and they develop marked stridor, don't try to give a racemic epinephrine treatment. Don't try to give cool aerosol. Just go ahead and re-intubate that patient, because the racemic epinephrine will take too long if it's marked stridor. Remember, marked is a key word for emergency. And so just go ahead and give them what they need, and that is a stable airway. So go ahead and re-intubate the patient, and you can try it again to wean and extubate at a later time once the inflammation in the airway is corrected. So, all right, well, that's just a quick review of mechanical ventilation, intubation, a little bit of weaning talk, and we'll go more in depth in future videos, but you've had 5 or 6 questions at least, and the answers during this Lunch and Learn. So I hope it helped. I hope you enjoy. Put your questions in the comments or message me with your questions, or Miss Jana, and we'll do everything we can to get you super confident in this area. There are a lot of questions on the test about mechanical ventilation, so we want to have you ready and competent and confident. Okay? So, all right, you have a great day.